All right. So thank you to the organizers for inviting me. It's a real pleasure and honor to be here. And so I'd like to talk about the work in our group at the Center for Computational Imaging and Personalized Diagnostics at Case Western Reserve University, where we've been really thinking about, for the last 15 years or so, about how we could use radiomics and artificial intelligence for better identification of prostate cancer and also stratifying the aggressiveness of prostate cancer on multiparametric MRI. And as of last year, I'm also a part-time federal employee thanks to a VA Merit Award from the VA, and consequently, I'm also affiliated with the Lewis Stokes Cleveland VA Medical Center. Some of my disclosures. All right. So the real premise of a lot of the work that's going on in our group is the fact that disease-specific information really resides across different length scales. And of course, prostate cancer is a classic case in point where one can look at a multiparametric MRI exam, look at the region of adenocarcinoma, and of course, one can look at multiple different types of MR parameters. You could look at the T2, you could look at the diffusion. One could also possibly look at the spectroscopic information with creatine, choline, and citrate ratios. And then, of course, one could also look at the vascular-related information from a dynamic contrast enhanced MR scan. If this patient were to go on to get a radical prostatectomy, now with whole slide scanning and digital pathology technologies, one can digitize the surgical specimens. And in their digitized form, one can now start to apply AI and computational image analysis tools to really interrogating the morphology of the tumor in a very quantitative and a very reproducible way. And of course, because one has digitized the pathology, one can also start to look at features relating to the shape of the individual nuclei and the individual cells in the pathology images. And of course, as is now the norm for a number of different diseases, we're routinely acquiring some sort of genomic or proteomic information. And so for that region of cancer that I showed on the MR scan, more and more, we're going to actually not just have the multiparametric imaging, but also pathology and some level of genomics or proteomics information. And so in our group, we've been really thinking about how can we leverage all of this information that spans different length scales to be able to align the knowledge from radiographic pathology down to the genomic level? How do we represent and extract knowledge from these various different modalities? And then how can we possibly combine and fuse the information across these different length scales with the goal of really creating fused predictors for improved diagnosis, prognosis, as well as therapeutic response prediction and assessment? A large part of what I'm going to talk about today is really focused around radiomics, or this concept of capturing representations from the image that are subvisual, things that a radiologist may not be able to visually ascertain from a radiographic scan, but essentially could tell us in a more quantitative, more reproducible way, features that relate to the morphology of the disease. And so the radiomic operators have really been around for a while. A lot of these texture-based features were developed actually in the early 70s and really have become the mainstay of what we call radiomics, fundamentally using mathematical operators to go in and characterize heterogeneity patterns on radiographic images and really extract or prize out texture-based measurements or texture-based responses. One can, of course, also start to look at shape-related attributes of the disease. The beauty is with these operators, one can really transform the radiographic image into a series of quantitative measurements that now reproducibly describe the morphology of the disease. Now, a big part of developing AI or radiomic-based classifiers for identifying the presence of disease or the aggressiveness of the disease is establishment of ground truth. One needs to have a clear ground truth for the disease presence on the radiographic scans. And so this is from work we published about 10 years ago, where we looked at a cohort of patients who got radical prostatectomy. They had had a preoperative MRI scan. The individual pathology images were digitized. A pathologist went in and marked up exactly where the tumor extent was on the pathology images, and then using deformable co-registration methods, we were able to then spatially map the tumor extent from the path onto the preoperative MRI. And why this was critical is because now this provided a more definitive ascertainment of where the tumor was or where the cancer was on the radiographic scans, with the consequence that now we could start to stand up radiomic-based or AI or machine learning-based classifiers for identifying disease presence using this ground truth annotation by rat path co-registration. We've actually taken this approach and applied it in a population-based way. This is work we published about 4 or 5 years ago, where we took a large cohort of patients, all of whom had had radical prostatectomy, applied the same fundamental process of co-registering the pathology to the MR, mapped the tumor extent from the path onto the MR. But what was nice now was that we were able to create a spatial distribution of the disease extent across an entire population of patients. So this was not a huge number of patients, about 80 patients, but essentially it allowed for visualization within one canonical framework, within one canonical representation of the distribution of the tumor, both in the transitional zone as well as in the peripheral zone, for multiple different patients. And you can see here the different colors representing the frequency of distribution of the disease within this one canonical framework. Now, this was also, apart from providing some visual eye candy, it was also useful because it allowed us to really make some discoveries. So this is work we published a few years ago, where we recognized that there were significant differences in the textural appearance of peripheral zone tumors versus transitional zone tumors. Now, of course, radiologists have long recognized this. A lot of you have known this for a long time, but this study we reported on a few years ago essentially was the first quantitative evidence that the quantitative radiomic patterns that we were extracting from the transitional zones and the peripheral zone tumors had to be different. In other words, you couldn't have an AI model or a machine learning model that worked across the entirety of the prostate. Depending on the particular zone you were in, you actually might need to invoke different machine classifiers because the radiomic patterns or the radiomic features in the peripheral zone versus the transitional zone tumors actually were different. Working with the group in Nijmegen a few years ago, we then wanted to understand whether radiomics could allow us to really distinguish between high-grade PIN versus inflammation versus atrophy versus adenocarcinoma, because of course we all know and recognize that inflammation, atrophy could really be one of the major confounders obfuscating the ability to identify where adenocarcinoma is. So doing the similar rat path fusion correlation, working with the folks in Nijmegen, we reported on a study where, again, mapped the tumor extent from path onto rad, identified areas specifically of high-grade PIN on the path, adenocarcinoma on the path, the areas corresponding to inflammation, atrophy, mapped it onto the MR, and teased out radiomic signatures that were unique for the adenocarcinoma versus high-grade PIN versus inflammation and atrophy. One of the things that we've also recently been focusing on are features of radiomic texture patterns outside the tumor. We've obviously focused a lot on trying to assess what texture patterns within the tumor might tell us about the aggressiveness of the tumor. More recently, we've identified, interestingly, that patterns outside the tumor, peritumoral textural patterns, might actually be very critical in telling us about the aggressiveness of the disease. So in fact, we've found that the patterns outside the tumor may potentially tell us, provide complementary information, potentially even more information than features within the adenocarcinoma in really distinguishing clinically significant versus clinically more indolent types of tumors. One of the other questions we've been asking is, can radiomics predict biochemical recurrence? So in a paper that we published a couple of years ago, we showed that these texture patterns from tumors on MRI was also able to tell us as to which patients were at risk for biochemical recurrence following surgery. More recently, we've actually shown that these radiomic features that are associated with the risk of biochemical recurrence on MRI are also strongly correlated with the risk categories defined by the Decipher test or the Decipher risk score. And so this was sort of an interesting observation because it goes back to the first slide I mentioned about the association of information across scales. So clearly what we're identifying on the imaging seems to have an association with what's happening at a molecular level, given that the Decipher test is a genomic-based test. One of the other features that we've also identified appears to do with the shape and the distension of the capsule, as well as the transitional zone. So this was a study that we conducted and reported on a couple of years ago, where we looked at a series of MRIs from patients who went on to biochemical recurrence following surgery, and then looked at another cohort of patients where the men did not progress to have biochemical recurrence. We created atlases for the different cohorts, the biochemical recurrence cohort versus the non-recurrence cohort, did essentially a difference operation where we looked at differences between the two atlases for the two populations and found, interestingly, that there was areas that were significantly different, not just on the surface of the capsule, but also within the transitional zone, suggesting that there are significant morphologic differences, distension differences in the capsule and the transitional zone between patients who do and do not go on to have biochemical recurrence following surgery. Obviously, this is a focal therapy meeting, so obviously I need to talk a little bit about some of the work we're doing with radiomics in the context of laser ablation. So a few years ago, we were funded through the NCI to do a study where we looked at radiomics to help with treatment planning for laser ablation, patients who went on to get laser ablation for focal prostate cancer. One of the things we also wanted to understand in the context of this study was what were the changes that radiomics could pick up post-ablation on multiparametric MRI. We looked at co-registering the pre-treatment and the post-treatment scans and found there were areas where there were significant differences, but of course, this was all coming just off the imaging. At the same time, we started a collaboration with Nijmegen where they'd looked at about 5 or 6 patients who had had laser ablation followed by radical prostatectomy. And so all of these patients had had MRI prior to the laser ablation. They had an MRI before the surgery. And so there, again, using rad-path fusion, we were able to map the thermal necrotic changes on account of laser ablation and the residual disease on the prostatectomy specimens back onto the preoperative MRI, and allowing us to really start to tease out radiomic signatures to distinguish thermal necrosis from residual disease. And this is just some other work where we've shown that essentially by looking at changes between pre-treatment or pre-ablation MRI and post-ablation MRI, what is the impact of the procedure on distortion or deformation to the bladder and to the rectum. So with that, I'll conclude. Obviously, I've got to acknowledge the amazing group of scientists, students, and faculty that I'm privileged to collaborate with back in Cleveland. And of course, you always have to acknowledge the funding agencies, the people who put food on the table. Thank you very much.